All right, good morning, everyone. Welcome to our first surgery of the day. I'm joining you from the conference room. We have Dr. Duke in the room with us while they get set up in the OR. He's here to answer some of your questions that you've been submitting on the website, on our app, and through the Spine Surgery Support Group, which is our Facebook group. So we're going to start off with some questions with Dr. Duke before he goes into the operating room today. And then as the stream goes on, you can ask more in the chat and he'll answer them live. So here is Dr. Duke. We'll begin with our first question, which I'm going to post on the screen now.
Okay, so we've already started our live stream. I was hoping to be able to get to a few questions and answers before surgery this morning, but we are trying a new format and we're working out some technical kinks. I'm Dr. Ara Duke-Majan. I'm a surgeon, CEO and founder of Duke Spine Institute, and we're live streaming from Duke Spine Institute Surgery Center, Viera. This is February 6, 2020. This first case we'll be performing is a Duke laser disc repair, L45, L5S1. This patient has herniated discs, L45, L5S1. And they're having a lot of back pain. Back pain is daily, chronic pain. This patient has tried conservative treatment. It has failed. They have a problem that can be fixed with the laser surgery that we perform here at Duke Spine Institute called the Duke Laser Disc Repair. This surgery is specifically designed to cure back pain and leg symptoms that come from herniated discs in the neck or back. Thank you. Left side, everybody in agreement? We're on the left side here. All right. This is Dr. Duke-Majan. As those of you who have watched these surgeries before, everyone knows the patients are awake for the very beginning. I need their help. We're going to get started, okay? So I'll be talking to you, the audience, as well as my team in the OR, as well as our patient. So there are three people that I'll be having conversations with: the patient, the team, and the audience. So nobody knows who you are, don't worry. And we're going to get started, okay? That's my hand on your back. All right? For the very beginning, I'm going to give you an injection of some numbing medicine. You'll feel a little stick and burn. Not a big deal. That's normal, okay? And if you have pain during the procedure for any reason, just say ouch. When you say ouch, we'll ask you where the pain is. You just say your back or your leg or both. Okay? All right. Remember, if you feel anything that bothers you, say ouch. I'll take care of it and make it more comfortable, but don't try to get off the operating table. All right, patients are asleep for the majority of the surgery. However, they're awake for the very beginning. All right, we've got our x-ray that we've taken. We use x-rays to navigate to the proper disc along the path to get there. It makes it much safer and more accurate. All right, we're going to get started. I'm just feeling back here, okay? All right. Little stick and burn. That's normal. I apologize. You know, Dr. Santiago has a lot of experience doing these procedures with me. Do we use bicarbonate?
No, sir.
All right. Didn't we talk about that?
Last case, yes, sir.
Why aren't we doing it?
It's all right. Yes, sir.
So, for those of you who have never watched a live spine surgery from Duke Spine Institute, it's the only place in the world you're going to find a live spine surgery. We've been broadcasting live surgery every week for the last 5 years. Part of live surgery means you get to hear our conversations. So if there's an issue, we're going to talk about it. This is the midline here, right?
Yes, sir.
Yeah. Normally we prep and drape to the midline or just past it, okay?
Yes, sir.
All right, remember, let me know if you're having any discomfort, and I'm going to make it better for you, but don't try to get off the table, okay? All right. So I know we have some questions already. You're welcome to ask them. I'll do my best to answer them while we get started here. Sean? AP?
All right. We have a few from our audience. They were asked previously. We have a spine surgery support group where many patients submit questions to us. We also have an app where we receive questions. This one comes from a patient on the Duke Spine Institute app. They submitted a question that says, if a patient has severe disc slippage that is causing major problems with walking, sitting, and sleeping, will laser surgery be able to help?
Yeah, well, so lateral. All right, so when I answer these questions, many of the times the questions are asked in such a way I can't answer them directly. I have to qualify my answer. When people ask me about does laser surgery help, the laser surgery that I refer to is the Duke laser disc repair. That's the procedure we're doing here today. So Jordan, without me telling you, you should be working on getting that disc lined up better. Work with the anesthesiologist, okay? I think you need the table down just slightly as well. So when I talk about laser surgery, I'm not talking about, there's a lot of doctors out there trying to do laser surgery right now, and they don't do the proper laser surgery. They don't do anything, in my opinion, that would actually benefit you. To do surgery with a laser that actually works for a herniated disc, you actually have to operate on the herniated disc itself. You can't put a laser on the skin and rub it around with someone's back and that's going to fix their problem with their disc. That doesn't work that way. You actually have to go inside the disc, and really the surgery we're doing is something called endoscopic spine surgery. We're doing a real surgery on the disc, and we're using an endoscope, which is a narrow tube with a lens and a camera to help me find it. That's really good. That you did a good job there. All right, so the laser part is just part of the surgery, and the laser is just a tool used to remove the herniations and release them from the scar tissue, and it's also a tool to debride the annulus. The annulus being the part of the disc where the real problem actually exists. That's where the tear is, shot AP. That's where the herniation has come out through the annulus. So the jelly in the middle, called the nucleus pulposus, a piece or two or three or five have come out through the tear that normally the annulus contains the nucleus inside the disc. And now what's happening is there's a tear in the containment part, the periphery of the disc. Go back to a lateral. And that tear is allowing the nuclear material on the inside to squeeze out. Kind of like opening the cap of a toothpaste and then squeezing the toothpaste and letting the toothpaste come out through the hole. That's really what we're dealing with. Are you comfortable? All right, well, there's our facet shot. Feel good about that. We're going to sneak around it. Shot. So how much IPM are you doing?
I'm doing mainly anesthesia at the moment.
So are you happy about that?
I gotta do what I have to do.
Well, I know what you have to do. Where do you feel that? How far down your leg? All right. Shot. All right. So what I'd like to do, I'm going to take a break from answering the question. I want to try to position this fluoro a little bit better. Let's drop the table ½ inch. Okay, stop. And release the wag. I'm going to try to move it a little bit better. Shot. I think that made it worse. Shot. That made it better. Wait. I mean, there's still a double shadow on the iliac crest, but the pedicle looks good. The end plate looks good. Go ahead and lock it in. Don't move it when you lock it. For some reason it moved. Why is that? Do you know? Shot? Huh?
Could just be moving a lot. It just tilts a little bit.
Shot? Shot? Anything? Anything? No pain in your back, no pain in your leg? Huh? What'd she say?
She said a little bit on her back, but nothing down the leg, alright?
Shot? Alright, let's get an AP just to double check. You're doing great, by the way. Everything's going perfect. So the answer is yes. A disc herniation in your back could be causing your symptoms, and it is fixable with the Duke laser disc repair. I would not trust any other laser surgery because the fact of the matter is that I know all the endoscopic surgeons out there. I know who's good. I know what they do, what they don't do. And I would say 95% of laser surgery you hear about out there is just a sham, a gimmick. Basically, they're trying to replicate what we do here that's successful. And I'm not going to mention any specific names, but there's a few really good endoscopic surgeons in the world, and then there's a lot that want to be endoscopic surgeons that are not really so good at all. And so, you know, Duke Spine Institute, we actually have 95% on average relief of curing of pain in the back, in the leg that patients have before surgery with our surgeries. We don't have 100%, but if you take all the patients that we've treated over the last 10 years and you add up the percentage of relief, you're at 95% on average. So some patients will get 80, some patients will get 100, but the average is 95. Now, nobody else has that good of a result because they don't do what we do. What we do different is not the approach. The part I'm doing right now is called the approach, okay? And most endoscopic spine surgeons are able to do this approach, which is getting to the problem. They can do it similarly to me. There's nothing greatly special about what I'm doing right this moment. But what sets my procedure apart from everyone else's is what I do once I bring the scope in. And what I do different is I do a debridement of the annulus. And I was the one who pioneered and discovered that technique. And that debridement of the annulus is what takes the pain away. And so other spine surgeons that do endoscopic surgery, they don't do an annular debridement. They just do a discectomy. And a discectomy alone won't fix the problem, Sean. That's what I learned a long time ago when I started doing these procedures, is discectomy alone doesn't fix the problem of back pain or neck pain. So I pioneered the debridement of the annular tear, lateral, and that debridement I published back in 2012. That was 8 years ago. So I realized that debridement was important around 2008, and then we started collecting data from our patients so we could publish our results. And in 2012, I published the technique after several years of studying the outcomes and the safety of the surgery. So what you're watching here is a very unique special surgery that we only do at Duke Spine Institute. There's nobody else in the world doing it right now. And the reason for that is that for surgeons to do surgical procedures, they have to be trained to do them. And the training happens with a surgeon like me who does the procedure and can teach that surgeon how to do it. And unless you're trained properly in a technique, you can't do that technique. I mean, but that doesn't keep some unscrupulous surgeons from trying to do it. Ones that are just motivated by money or greed and not really patient safety or efficacy. And so you may hear about laser surgeries being done that don't work and that are dangerous and have bad results, AP. But they're not the same type of surgery we do at Duke Spine. So don't think that just because you're getting quote-unquote laser surgery that it's the same. So when I answer your question about laser surgery, I'm talking specifically about Duke laser disc repair. I'm not going to vouch for other laser surgeons and their technique because I didn't train them, and I don't think their results are anywhere near as good as ours, and more importantly, they haven't published their results. By publishing your results, and I'm not talking about publishing on the internet, I'm talking about a process of peer review and publication. It's a scientific process. It's essentially tried and true. It has some hiccups and problems with it in this day and age, but those problems are related to relationships between authors and reviewers, which I don't have because I don't have any friends up in high places. So nobody does me any favors of publishing my paper and me scratching their back by putting their name on the paper. That doesn't happen in my case, but it happens in a lot of other cases, unfortunately. So you get non-scientific garbage being published in medical journals now that really has been peer-reviewed, but it's completely biased and it's unscientific. But when I did my publication, it was peer-reviewed by basically my enemies, who are very upset about the fact that I figured something out that they didn't. And so they did everything they could to not publish it, but at the end, it was published because it's good science. That's why. You can't deny good scientific evidence. You can't deny fact. You know, just like the guy who said the earth was round, the first person that said that, you know, eventually it bore out as true, because it is true. It's a fact. And people can say, no, it's not. The earth is flat. The earth is flat. The church could say it's flat. The Pope could say it's flat. But eventually, people are going to figure out it's round. They're going to learn the truth. So, in the end, the editor-in-chief, Professor Emeritus Dr. Jim Osmond from UCLA in Los Angeles, he said, my God, this is great stuff. It has to be published because it's real. And we don't care that the reviewers are biased because they don't do this procedure. But there's a lot of jealousy and envy that goes on, unfortunately, in spine, and there's a lot of greed. But in the end, we broadcast these surgeries live so other surgeons, other people can learn how to do them, and they can get better care. All right, are you comfortable? I have good news for you. We're going to be able to put you to sleep soon. All right, I just want to make sure you're comfortable. What are you feeling? Is that your typical pain? How bad on a scale of 1 to 10 did it get? All right, well, that was the L45. That was the top disc. That's a problem. And you have a big tear. It's a grade 4 tear, and you can see the herniation, and I can see the tear in where the dye is leaking out. So that one's definitely painful, and when you wake up, that pain will be gone. Won't that be nice? But you know there's another disc we're working on. How bad is that on a scale of 1 to 10?
7.
Another 7. You're pretty tough, you know that?
Yeah.
Yes, you are. All right, I have good news for you. We're ready to put you to sleep. And when you wake up, we'll be done. All right, so go ahead and count from 1 to 100 out loud. But for starting at 1, I want you to count in Swedish.
Oh, no.
All right, Canadian. Canadian. Nice and loud. All right, everything's going well for her. And we're in the right 2 discs. They're both painful. 7 out of 10 concordant on both of them. I can see tears in the back of the disc where her pain is coming from. And we're going to go in there with a scope now. We're going to find those tears and we're going to debride them. All right, what's our next question, Sean? You're doing great. Count out loud. Shot. Go ahead, Sean.
Our next question also comes from the Duke Spine app. One of our viewers asks, what disqualifies someone from being a candidate for cervical DLDR? Are the anatomical requirements for you to access the disc different than in the lumbar?
Oh, great question. So one of our viewers on the app, the Duke Spine app, Duke Spine Institute app, which by the way, our app is free, and you can download it to your Apple device or your non-Apple device. We have both iOS supported app and a Android supported app. So for those of you watching off the internet through the website, I recommend checking out the Duke Spine Institute app. It's free to download. It has lots of valuable information and neat stuff to look and learn about back problems and neck problems. So the question is there any anatomical constraints when you do a Duke laser disc repair on the neck for the cervical spine when somebody has a herniated disc in the neck? Is there anything different there that could keep you from doing the surgery compared to the lower back? And the answer is yes, for sure. Cervical spine disc herniations are more difficult to treat. They're technically more difficult. The whole surgery is done with a tube that's half the diameter of the lumbar, and the scope is a different scope. It's a fiber optic scope versus a rod lens scope. The fiber optic scope for the neck has 50,000 fibers. Sorry, not 50,000, 5,000 fibers. And the images are projected through those 5,000 fibers. You ready? Yeah, to the camera. And the camera projects that image to the screen. So with a rod lens scope, like I use for the lower back, you get an actual image projected through lenses rather than through fiber optics. So that's one difference. As far as access, yeah, somebody with a really thick neck maybe too thick for me to safely do the surgery. So if you have like a football player neck that's super thick, and honestly, I've only had to terminate one surgery out of about 500 cervicals over 15 years. I had to terminate one because I couldn't get in safely without risking a complication. And so thick neck, I can usually take care of a thick neck and do the surgery, but a really thick neck would be one consideration. All right, let me just get this started. Shot. Shot. Okay, so we placed our dilator into the disc. For those of you watching, can you see the patient's back here?
Yes, we can.
All right, so let me show you. The entire Duke laser disc repair surgery is done through a tube, a metal straw. It's just like a shake straw. If you go down to and get a shake, it's a nice straw. It's 7 millimeters wide, and of course it's FDA approved. It's designed and engineered and manufactured in Germany, and it's a high quality product. But it's a tubular retractor. Its purpose is to, create a passage for me to do the surgery, and I do the whole surgery through this one tube. I'm going to take it out later to do the second disc shot, but I basically slide the tube down the dilator. The dilator has a tapered tip. You can see it sitting inside the disc at L5S1. That tapered tip is very gentle, and it doesn't damage tissues. It just spreads them. Okay? So the dilator that I'm sliding the tube over becomes a path. Shot. A path for me to get down and do my surgery safely. Shot. And I want to make sure the dilator doesn't go in any further. There's not much in front of the L5S1 disc that I can damage, but I don't want it to go outside the disc. So I just want to, we're good right now, but I want to make sure it doesn't advance. So that's what I'm looking for. Shot. I'm advancing the tube, the retractor, over the dilator, but I don't want to advance the dilator anymore. Where are we at? Shot. So I'm going to pull the dilator back just a little bit. And we're going to continue to advance the tube. Shot. And then I'll remove the dilator. Shot, so I can do the surgery. The tube is now entering the disc right through the tear, by the way. Shot. So that's one of the beauties of this particular procedure, is that the Duke laser disc repair goes into the spine right through a natural hole that's already there. We're not making any new holes. All other surgeries that are done around the world, except for transforaminal surgery in the lumbar spine, all the other back surgeries, the surgeon is making holes in the spine. Of course, lateral procedures through the side can also be done without making a hole in the spine. But essentially all surgeries done through the back, like microdiscectomies, laminectomies, they all make a hole in the actual bone in order to take the disc out. Shot. You're pulsing, right? All right, so our tube's in perfect position. I'm taking the dilator out. For those of you who didn't see it, here's what it looks like. Can you all see this?
Yes.
Okay. It looks like a pencil. You can write with it. But it's obviously not a pencil. It's like a $1,500 pencil. So my son likes to buy expensive drafting pencils. He loves having the weight, because a drafting pencil, I used to use a drafting pencil when I studied in college. The way it balances in your hand, the weight balance and the way it's engineered is just very special. But drafting pencils can be expensive, a couple $100, but this thing takes the cake for the most expensive, right? Pencil shaped structure, but it's basically designed to spread the tissues so you don't damage them. And then we bring the tube down over the dilator. So now we're inside the herniation. We went right through the tear. So I went through the bad part of the disc that's already damaged. And that's another thing that's nice about our procedure, is that not only are we not taking any bone and making holes in your spine to get to the disc herniation, we're actually going through the damaged part of the disc rather than going through a normal part of the disc to get to the damaged part. So if you have surgery through your belly, if you have surgery through your side, the surgeon is going through normal discs to fix your problem. So that's causing what's called collateral damage. Can we move the monitor, please, to the side? So just so you can all see, pull it towards you a little bit. Just bring the whole thing. You may have to loosen the arm, the boom arm. Look at those knobs right there. You see those knobs? Will you help him, Dr. Santiago?
Yeah, from this not can be both.
Please be very, very gentle with it. Yeah. And that's nice. And just turn it. Turn it a little bit. Perfect. The other way. Yep. Yes. Perfect. Thank you. Okay, so what we're looking at, folks, is the inside of the disc that's herniated. And the blue stuff is the dye that I added earlier. And the dye helps me find the bad parts of the disc, the nucleus pulposus that has been degenerated as a result of the herniation, and the action of the body on that nuclear material. I think we're overexposed. Can we bring... Yeah, that's... Maybe one... that's too much. Just go back up one. All right, that's good. All right, now we have the laser fiber, and we're going to start our laser procedure. Now, this is where we differ from everybody else. A lot of other surgeons that do laser procedure, and there's not many, but they just, they don't see the actual part that they're working on. They don't understand it. They just stick a laser down a needle, or they put a laser on your skin. Anyway, that's not going to work, folks. And it gives a bad name to laser spine surgery. So the Duke laser disc repair is a unique procedure, and no one else can actually do the Duke laser disc repair. We have the procedure name is register marked, and the procedure itself is only done at Duke Spine Institute currently here in Florida. So there's a lot of people who are quote unquote imposters who are trying to replicate what we do, but if they can replicate what we do exactly the same, great. I would encourage you to get treatment there. On the other hand, I make these surgeries look pretty easy, so a lot of people are deceptively led to believe that they're easy to do, but they're not. There's a lot of things that can go wrong, and if you don't have the right surgeon doing your surgery, why are the shoulders so high here?
It's a strap. It's a strap that we put.
No, it's not the strap. It's not just the strap. It's impeding my ability to move my scope. So I don't know what we can do to reduce that.
Can we take Grace out? Or
Is
mine,
that...
whatever you want?
Luis, these are things you have to be paying attention to,
Yes, sir.
okay? That's your job, is to make sure stuff like this doesn't happen. It could be. The whole shoulder appears to be elevated to me. So maybe the way the pillow's sitting underneath her. So whatever you can do. I mean, if worst case scenario, I can work around it, but it would be better for me to have no pillow obstructing my hand. All right, so go ahead and let's go with some of the other questions that we might have. And I'll explain what I'm doing as I go along. Right now, I'm just debriding the annular tear and removing the herniation.
We have one question that was asked on the spine surgery support group. You'd already touched on it previously, but the viewer shared their story. They said, I recently had a discectomy at L5S1, and my surgeon recommended that I begin walking a mile per day to ease the spasms and muscle aches. I listened to his advice, and now I have shooting, stabbing pain down my buttock, leg, and back. I've tried muscle relaxers, prednisone, Mobic, Tylenol, hot compresses, but nothing gets rid of the horrible burning. What can I do?
Well, it's a great question. So I was earlier commenting on a post in the spine surgery support group where one of the members was talking about reflex sympathetic dystrophy and complex regional pain syndrome, and and its role in postoperative pain of this type. So just to be clear, the fact that your pain after surgery is shooting down your leg intermittently, in other words, it's not a constant burning that never gets worse, never gets better. It is literally the same, no matter what. Reflex sympathetic dystrophy, which is a very rare condition, and it's unusual, it causes a constant burning throughout basically the whole leg, and you would not have a stabbing pain. You would not have shooting pain. It's just burning constantly, and the skin is horribly sensitive. You touch it just lightly, and it hurts very badly. We call it allodynia. Allodynia means you touch the skin lightly, and there's a very painful stimulation. Those are characteristics of reflex sympathetic dystrophy, which I don't think this patient has. Also, they get joint changes in reflex sympathetic dystrophy, where their joints hurt, and a lot of that's due to traumatizing the joints from the way you're walking, because you're not having normal sensations, so you're not protecting your joints like we normally do when we walk. I think this patient who's posting the question is having residual stenosis or recurrent stenosis. Stenosis means narrowing. So basically you have a pinched nerve once again. And that pinched nerve is causing your symptoms to shoot down your leg. And that's what I think you're going to find, that there is stenosis on your MRI. Now, I will be honest with you, it's unfortunate, but many MRI radiologists, those are the doctors that read the MRIs, they miss the stenosis. They miss it. They just don't see it. You know what I mean? And that's one of the reasons why we advocate for people to get MRIs done at a high-quality imaging center that has really good radiologists. Unfortunately, radiologists miss these things because they've been cut on their reimbursement, so now they're trying to read more studies in less time, so they're really going through these studies quickly and just putting the basics of what they see. Is there a fracture, tumor, infection? Those are the things they're going to get sued for if they don't mention them. So they're really hitting on the main, bad things that could be there, and they're focusing on those issues, but they miss the subtle things that cause symptoms like pain. So that's just the reality of it. I bet that this patient, if they were to get a new MRI, there would be evidence of a pinched nerve or an irritated nerve from a herniation, a residual or recurrent herniation. So that's what I believe is the cause of your problem. What percentage would I say likely that is? I would say 99.5%. Okay? Could I be wrong? Sure, I could. But the only way I could tell for sure is to look at your MRI and make that determination. But from everything I'm hearing, as an experienced spine surgeon, you have a pinched nerve in your back that's going down your leg with those symptoms, and it needs to be fixed.
Yes.
I don't know why it happened that you got a recurrent herniation. I'm assuming your symptoms went away after surgery and then they came back with all that walking. If that's the case, then you re-injured the disc and you spit out another piece that's up against the nerve. I just think it's being missed by your surgeons or the radiologists, which is very common, by the way. I hate to say it. But if you can get me a copy of your MRI, I'd be happy to do a free review and tell you my opinion and sit down with you on the internet and go over your MRI and show you where I think the problems are and what needs to be done to fix it. If I'm right about this and there's another bulging disc or herniated disc pinching the nerve, the surgery you're watching right now is the very best in the world you can do, because we're not going to take any bone away from your spine like your other surgeon did. So we're not going to have to weaken your spine any more than the other surgeon did from the microdiscectomy. Microdiscectomies, in my opinion, are bad procedures. They shouldn't be done. They're completely unnecessary, and the Duke laser disc repair should be done instead, because the Duke laser disc repair is more effective at treating back pain, which microdiscectomies don't really treat very well at all. And the Duke laser disc repair does not involve removing bone from your spine. When you have a microdiscectomy, the surgeon has to take your lamina out and part of your facet joint to be able to get to the herniation. And I've done hundreds and hundreds of microdiscectomies in my career before I learned the Duke laser disc repair technique. And now that I know this technique, I would never recommend a microdiscectomy to anybody. There's only a few circumstances where a microdiscectomy may be better, and that's when you have a herniation that migrates south or north and it's behind the vertebral body. Then you really have to do a laminectomy to get to it. But that's a very rare scenario. Most disc herniations are at the level of the disc, and they're accessible through a transforaminal surgery like we're doing now. But again, it's something I can determine easily ahead of time with the right MRI. And if you're wondering, well, if the radiologist reads the MRI incorrectly, then how will I know? Because I'm capable of reading my own MRIs, folks. All good spine surgeons can read their own MRIs. And we do. We would never do surgery on a patient or recommend treatment to a patient without being able to see the MRI ourselves and be able to tell you that we either agree with the radiologist or we disagree. That's an expectation that you as a patient should have for your surgeon. Your surgeon should be able to read your MRI themselves. If they can't read the MRI themselves, they shouldn't be doing surgery. All surgeons in the United States are trained during our training to read MRIs of the spine, the brain, and we're experts at reading them. And we read them better than the radiologists do, because that's our area of expertise and is surgery on those areas, so we have to know those areas very well. As a matter of fact, my training at University of Florida in Gainesville in neurosurgery, I spent 3 months on the radiology service just reading MRIs and CAT scans and x-rays of the spine and brain, and that's part of everyone's training in the United States. Every neurosurgeon has to have neuroradiology, and the spine is part of neuroradiology, so we become experts at reading in a way that most radiologists in the community, we read better than they do. So your surgeon should be able to read your MRI and tell you what's wrong. It should be very easy, like brushing your teeth properly or blowing your nose for us. It's part of our everyday repertoire of skills and knowledge that we have. All right, this is the tear that I'm working on at L5S1, and it's a pretty bad tear. It's pretty scarred in from all the inflammation. It's been going on for a long time, but we're making good headway, and I expect to have this fixed by probably 10 minutes from now. I should be done with this disc. Then we can move on to the L45 disc. What questions do you have for me? Sean, you have another question?
No, we do not have any right now.
No questions, all right. The end plate is right there. That is the end plate of S1. This is the tear, and the herniation is blue. And I'm looking kind of at the bottom of the tear right now, right where the tear meets the end plate of S1, the superior end plate. And this herniation is just super, what we call collagenized, which means scarred in. This is a huge tear. It goes from the top to the bottom of the disc. Top being the L5 end plate, the bottom being the S1 end plate. So for those of you who are anatomists, we're in the neural foramen, and we're looking at the disc herniation. This is the posterolateral part of the disc. There's some fat right there. And the fat's getting in my way of me doing my job, so I have to deal with it. The laser is a very effective way of dealing with a little bit of fat that kind of billows out at 12 o'clock position, which is medial in the foramen. I do want to get this herniation here because this is definitely a problem for her right here. So I want to make sure I address it. You know, and that's another thing about your surgeon is they got to know not just how to do a procedure, but they got to know how to do it right. And that's truly in spine surgery. One of the biggest problems today is there's lots of people getting spine surgery, but the surgeons don't do their procedure right. So there is no, like, you know, at a stop sign, you have to stop, or at a red light, you stop. It's easy. You either stop or you go. But in surgery, there's hundreds and hundreds of different ways to do the surgery. And even if you're talking about a microdiscectomy, there's probably at least 20 different ways that surgeons commonly do it that are dramatic and important differences. And every surgeon does it a little bit differently. You'll never, if you take the same patient, you have 20 spine surgeons do a microdiscectomy, you're literally going to have 20 different surgeries. Even though the name of the surgery is the same, and the concept of what you're trying to do is the same. It's just like bridges, right? Think about a bridge. I mean, there's lots and lots of bridges, but they're not all the same. No two bridges are identical. They're all different. They're different because the depth of the water is different that they're crossing, the span of the water is different, the height is different based on the needs, you know, for shipping and whatever else, wind, turbulence, etc., etc. My point is no two bridges in the world are the same, yet there's million bridges out there around the world. Well, same thing with microdiscectomies or spine surgery. No two spine surgeons are the same, and no two spine surgeries are the same. Now, bridges, you know, you like to believe that they all serve their basic purpose of, you know, not falling and being safe and allowing crossing both under and over. But the reality of spine surgery is there's no regulation on the bridges, on the spine surgery. People just graduate their program after a fixed number of years. So all neurosurgeons take 7 years of training. And at the end of the 7 years, you could be the worst spine surgeon in the world, but you're still graduating and you're still going out and doing spine surgery. And unfortunately, that's true for all doctors, whatever specialty there is. The residency training program is supposed to ensure that those doctors are trained properly. But the reality is that if they're not trained properly, that residency was responsible for not training them properly. So they don't want to say that they weren't trained properly. They had 6-7 years to do it. Why the hell didn't you train them properly, right? Everyone's going to say, you had plenty of time. Why didn't you make sure it happened? The reality is that it's very difficult for a lot of the residency programs to train their surgeons properly because they may not have the resources, either the surgeries, the surgeons there. Yeah, but you got to tell me switching so that I'm prepared for the bubbles and the lack of water, right? So that's why there's so much variation in the way surgeries are done around the world, is because there's variation in the way surgeons are trained to do surgery and also not trained. I'll give you an example. This surgery you're watching, I was not trained to do in my residency. That's why nobody else in my program knows how to do this surgery. I learned this surgery after I got done with my formal residency training. I learned it overseas and domestically from one surgeon. And I developed my own technique. So my point is, if I had not gone out on my own and learned this surgery from a surgeon who was doing it in the United States, then I never wouldn't be able to do this type of surgery. Now, all the other surgeons that I trained with at the University of Florida or anywhere else in the States, they're not trained on this type of surgery. They would literally have to go after their training and go do a fellowship for a period of time to learn. And that's what I did. I went and did a fellowship. So I did several, actually. So I took time out of my practice, out of my family life, I flew around the world to learn this endoscopic technology, and I learned from several surgeons, and I took the best from each one, and I brought it back, and then I learned on my own the right way to do things that made it better for the patient, safer, more reliable results, and I developed this surgery. So how many surgeons do that? Very few. How many doctors do that? Very, very, very few. Why? Because they're happy just, going to their fellowship or residency and doing their training and then coming out and just doing what they've done during their residency. They're either afraid of change, or they're confident in what they're doing incorrectly, believing that it's all there is available. So I'm talking about this because people need to understand, if their expectation is to go to a surgeon and that surgeon is going to offer them the most advanced surgery in the world, they're wrong. The surgeon's only going to offer them what they do. And if they've never learned endoscopic spine surgery, they're not going to be able to do it. And that's a good surgeon. A good surgeon, believe it or not, is someone who recognizes that they can't do things that they're not trained and prepared to do. And they'll be honest with you and say, I can't do it. But the bad surgeons are the ones that I really worry about. Those are the ones that lie to patients and tell them they can do something that they really can't do. And that's dishonest. And that's one of the reasons why we do this broadcast, is so that people can learn to distinguish between honest and dishonest, but they have to know that there's a difference to begin with. We all know, for example, when we're hiring a plumber to repair something in our house, there are good plumbers that are honest, they work hard, they do the right thing, and they charge you fairly. And then there are dishonest plumbers. Okay, and that's true for everybody. Roofers, plumbers, electricians, you name it, car repairs. We all know that there's places to avoid and there are places that you can go to. And believe it or not, even those auto repair shops are better regulated than spine surgeons. I'm just working lateral now. This is the lateral part of the herniation. There's not many endoscopic surgeons anyway in the world, but many of them, most all of them, don't know about this part, and they don't treat it. But you have to look laterally in the foramen and see if there's a tear and a herniation. You can't assume everything is medial towards the midline. This is one of the things that I think endoscopic surgeons fail to do. And this was taught to me by Dr. Anthony Young, to go lateral and check. I give him credit for what he did. He was probably the most influential of all of my instructors in endoscopic spine surgery. Dr. Young is now close to 80 years old, if he's not already there. And I don't know if he's still practicing or not. His son, Chris, is a friend of mine, and Chris likes doing more complex types of spine surgery, but I know that my son someday may be a neurosurgeon, and I would hope that my son and daughter both would consider doing the Duke laser disc repair as part of their procedure for fixing people. All right, just about done. This is taking longer than I expected because the disc is so scarred up from inflammation. This has really been going on for years and years, and when people ask me how long should I wait to get my disc fixed or my back or neck fixed, I say right away. Don't wait. If you've already had pain for 6 weeks, then you failed conservative management. Come in and get your disc fixed. The longer you wait, the more inflammation and scar tissue you have to deal with. This is all scar tissue. If this patient had come in right away right after their injury, then they wouldn't have as much scar tissue. It would be a much safer and faster surgery for her. But that's true for everybody, though, not just this patient. Most people wait too long. Waiting too long to fix a herniated disc can cause nerve damage that's permanent. It can also cause, obviously, a lot of other problems, deconditioned muscles, joints. So I recommend getting these things fixed right away. Give it 6 weeks of conservative treatment, even try some shots. But don't wait longer than that, because your muscles start to decondition, your joints start to decondition, and you start developing secondary sources of pain that are really hard to treat. All right, I'm happy with that. Laser off. That's L5S1. Hold on the scope. Yeah, I'm happy. There's a nerve, by the way, right there. That's the left L5 nerve root. Standby scope. This is really the most elegant spine surgery. I've done all spine surgeries there is. And this is just the most elegant, delicate, and just amazing the amount of relief people get with such a small procedure. Such a minimally invasive procedure. Now, I could fix this patient's back and leg pain with an open surgery called a Duke spinal fusion. But then she would have to have screws and rods, and she'd have a lot more pain recovering. So there's really two choices that work, in my opinion, that give people the best results. As a matter of fact, equal results in my hands. If I did a 2-level lumbar fusion on this patient, I could get just as much pain relief as the laser. But the patient would be laid up in bed in pain for a few weeks, and they would be on restrictions for months, and they would never, they would take 6 months to get back to a normal life. With the laser surgery, we're talking about getting back to a normal life within hours or days. Sometimes it takes a little longer if you have more muscle weakness before the surgery, and you have to do longer therapy. But probably 90% of the patients we do the surgery on are back to a normal life within a few days. All right, questions? Or
Yes.
should I keep rambling?
We do have one question.
Uh-huh.
One of our viewers wonders, do you take post-operative MRIs to show that you actually repaired the disc, or how do you know?
Do we take post-operative MRIs to show that we actually repaired the disc? The answer is no, because we don't need an MRI to show that we repaired the disc. There is nothing better to show you've done something than actually seeing it with your own eyes, and that's what the endoscope does. It actually shows you that we took the herniation out. So it's better than an MRI. MRIs are, using magnetic waves to create some image that you then interpret structurally based on a computer that basically reconstructs an image based on magnetic waves. So you're not really seeing the actual herniation with your own eyes. When you do endoscopic spine surgery, you're looking right at it with the scope. There's no better test in the world. As a matter of fact, if there was a way to do discogram with endoscope to diagnose disc problems, that may be even better than an MRI. But it's invasive. That's the only problem. But see, we're already doing the surgery, so we're already here. So it's not like we're doing an invasive test because we're already looking at the disc. So there's no point to do MRIs after the surgery because the patient's symptoms go away. And we know we fixed the problem because we saw it with a scope, the patient's symptoms went away. Doing an MRI scan would be a good way for me to make more money, but it would be totally unbeneficial to the patient because it wouldn't change what we do to manage them. All right. Are you ready? Let's start the next disc. This is going to be L45. Shot. Shot. All right, so you can see the tip of the dilator is in the foramen at L45, and right in front of that tip, you can see a curve. That dark curve is the herniated disc. We're going to push it back in to the disc, and then we're going to take it out from inside the disc. It's called the inside-out technique. And that's a technique that Dr. Young taught me. That's one of his techniques. So you can see how my surgeries are a combination of my teacher's techniques, and everyone does it different. And then, of course, I have my own techniques of what I do. Most notably, the annular debridement was my biggest contribution personally to the surgery. Shot. And probably to the world of spine care for the future. Shot. Just like Thomas Edison discovered, right? What does he discover? The light bulb? And now people use light bulbs for all kinds of things. Growing plants, you know, looking down into orifices, etc., etc. The technology now is used universally, and it's used to improve people's lives. Shot. So you can see the tube right there is at the back of the disc. So I'm going to introduce this retractor through the tear, just like the dilator has gone, and then I'm going to bring the dilator back out. And we'll be ready to do this disc. Shot. So some people ask me, why do you use a hammer? The reason I use a hammer is the tube I'm doing the surgery in needs to go forward down into the disc, and it won't go by itself. So either you have to push it with your hands or you have to tap it in. And pushing with your hands would be a very big mistake, because you could suddenly, you know, your resistance can go away, and then you just push the tube right into their belly and through the spine into the pelvis, and that would be really bad. So a hammer allows a surgeon to basically prescribe a very specific amount of force in a controlled fashion in a very short burst, and that's what you want for safety. So I've never had a complication with the hammer. I use it in all my spine surgeries virtually, and open and endoscopic. So do other surgeons. Using the hammer is pretty standard in orthopedic and spine surgery. So that's why we do a hammer. Hammer is very, very useful. And despite the fact that you might associate using a hammer inside someone's body or with a tool around their body, it would be unsafe, it actually increases the safety. So it's counterintuitive. All right, any other questions? We're going to be done in about 10 minutes. 10 to 15, yeah. Is our next patient ready? All right. Any other questions, Sean?
None at the moment.
Stand by. So going back to the other question about the MRIs, and I think it's a very fair question about whether we do MRIs after surgery. We don't do MRIs after any spine surgery. It's not just the Duke laser disc repair. There are literally 1 million spine procedures done every year in the United States, spine surgeries. And if we got MRIs after every procedure, that would raise the cost of healthcare by 1 million times. 1 million times, let's just say 1,000 on average. So what's 1,000 million? Huh? It's 1 billion. It would it would raise costs by $1 billion. So, for what? For nothing. You know, you don't judge your outcome of spine surgery based on what an MRI looks like. Pure and simple. So it's not just me that doesn't get MRIs after surgery. No surgeon that I know of in the world gets an MRI after surgery. There's just no point. You're treating a patient's symptoms. You're not treating an MRI. If my goal was to make the MRI look good and to, I don't care what the patient experiences, then I would get an MRI after every patient. And then I would claim victory. I would claim success after every pretty MRI. Doesn't matter if my patient's writhing in pain after surgery. I would just high-five myself and say my MRI looks great. Who cares what the patient's doing? But no. Healthcare is something called patient-centered, patient-focused care. It basically means we're treating a patient, not an imaging study. And that's where a lot of people go wrong, is they think, oh, we're trying to make this imaging study look good. You know, and this is a problem that spine surgeons have in general. They get x-rays after their surgeries, and I do too, and then they high-five themselves because the screws and rods are perfect, but the patient's crying in pain. And they just say, yeah, well, the fusion went perfect, so, you know, we've done everything we can do. No, you didn't. That's the problem, is they didn't actually address the patient's source of pain. And that's where Duke Spine Institute separates itself pretty much from 95% of the other spine surgeons out there. Is our focus is the patient, not the imaging studies, and not, you know, other things that are not important in medicine. It's the patient. You're there to fix a patient's problem. So that's what we do. We do it very, very well. And an MRI after surgery is totally unnecessary, and it's just going to drive the cost of healthcare up even higher. Now, if there's a problem, if the patient has a, you know, unusual pain or develops some type of symptom after surgery that could be related to a problem in where the surgery was, then yes, we would definitely get an MRI. We would want to figure out what the problem is. But that's extremely unusual. We probably get MRIs on 1 in 100, maybe 2 out of 100 patients that have this surgery, because they develop pain after the surgery. And 1 out of 100 of those patients will have a recurrent disc herniation where I operated. So if we operate, say, at L45, that 1 in 100 will have another herniation at L45 right where I operated. And that's usually because they've done something they shouldn't have done. And I say usually, I really mean that tongue-in-cheek. It's virtually always because the patient has lifted something too heavy, they've you know, stretched in a way they weren't supposed to, or, you know, picked something up from the ground when they weren't supposed to, and they were feeling better, and now they did that and they re-injured their disc. So as long as you follow the instructions that I give, 99% of the time you're going to heal perfectly without any recurrent herniation. If you 1 out of 100 though may do something that, oh, well, we didn't talk about that. You know, you never said that I couldn't go bungee cord jumping after spine surgery, and I did, and now I re-herniated, right? Well, you can, but you got to give your back a year to heal. So after a year of healing, then you can go back to full activities, unrestricted, okay, after my surgery. But before that year, your disc is healing every single day, and it's getting stronger and more reliable and more durable every day. But until you get to that 1 year mark, you better take it easy. By the way, these are what annular fibers look like. We're just about done. There's the epidural fat to greet us, saying hello. Why is there fat around the nerve roots? I'll give Luis a chance to redeem himself.
Again?
Because he gave me the wrong mask today.
What do you mean?
He spent my money buying the wrong masks. I will say those surgical masks are in high demand, so we could probably go out on the street and sell those ones. Right?
You can do it right now, yeah. I mean,
Yeah, this is February 6, 2020, and there's a virus going around in China that was manufactured by the Chinese for for military purposes. Actually, they're just taking after the British. The British manufacture viruses all the time so they could sell their medications to their population. But this is a virus that kind of was a little bit too aggressive and it's killing people. So these pharmaceutical companies, they want to manufacture viruses that just make people sick, so they'll buy their drugs. But they don't want people dying because that's bad publicity if they ever get caught. They may actually be held accountable. But in all seriousness, coronavirus out of China right now has basically shut down all importation of Chinese people or people that have been in China into the United States. I don't know what's happening in other countries. I think in Mexico they just shoot them as they come off the plane. You cannot use a surgical mask? It'll go through the surgical mask. Interesting. I don't know. Dr. Santiago, you probably know more than I do about this virus. Is it respiratory droplets or is it contact? Respiratory droplets? So you want to avoid breathing in respiratory droplets. Most viruses are transmitted by contact, not respiratory droplets. So that's why I'm wondering which it is. But obviously, it's a very serious condition, and we take it seriously. But we just need to be very careful. You see a lot of people wearing surgical masks, and believe it or not, we have trouble getting surgical masks right now because there's so many other places buying them, maybe for this purpose. Standby laser. I think Amazon is having a sale on surgical masks. I think Amazon recently hit $1 trillion in valuation. I keep telling my wife we should buy stock in Amazon. Jeff Bezos, who's the owner of Amazon, just built a rocket engine facility to build rocket engines just down the street from Duke Spine Institute, literally 15 minutes away. And I've been by the facility, and it's 500,000 square foot building, and they're building the second phase, so they're going to have almost 1 million square feet of fabrication right near Elon Musk's facility. The name of Jeff Bezos' company here is called Blue Origin. Blue Origin. And they're building the future rocket engines for space travel. Seems like everything he touches turns to gold. I wish Jeff Bezos would use some of his billions of dollars to help people suffering needlessly in pain. It really irks me to see billionaires who have billions of dollars and they're not sharing it with the rest of the community that doesn't have enough money to afford food or education for their kids or clothing or medical care. It's sad. All right, we're just about done here. It's been one of my goals at Duke Spine. I just haven't been able to do it, to have a free clinic where we can take care of people who don't have any money and have back problems or neck problems, and even provide them surgery like this. We have a foundation, the Duke Spine Foundation for Research and Education, and unfortunately, we don't get any donations. So I think people just don't have any money to spend. But I know Jeff Bezos does. I know, what's the guy that owns Facebook? Mark Zuckerberg? I know Zuckerberg does. I could tell you what I would do if I had a donation big enough. I would hire Dr. Santiago. That would be the very first thing I did. Best anesthesiologist I've ever worked with. No, we're done. All right. I guess we're done here. The nerve right there, you see the white thing there in the corner at 11 o'clock? That's the corner of the nerve. There's the herniation. Better than an MRI. You can see it's gone. Thank you very much, everyone. It's been really good. If you have questions, type them up. I'll go to the command central and answer them. Why don't you take a look here and see what we've got going on? Can you all see here?
Yes, we
Light
can.
on. So basically, bloodless surgery. We literally lost a drop of blood. You know, none of these things have blood on them. Okay? There's no blood. Okay? No blood. So if you want bloodless back surgery, come to Duke Spine Institute. Look at that incision. All right? I even signed my name, but this is legal. I'm allowed to sign my name on the skin. Okay? I don't do stupid things like other surgeons signing my name inside the body on organs. Yes, believe it or not, that's happened. Not with me. I think some guy carved his name into a uterus. Oh yeah, no, stupid people. But no, this is legal because I have to put my initials on every patient I operate on. So
Oh, I'm so sorry. We are so happy. I can't even tell you.
who's happy?
So happy to see Dr. Santiago.
Oh, I know. Yeah, we want him.
So happy.
Just when he tries to leave, pop his tires on his car. You know.
What are we gonna do?
I'm trying everything I can do. I don't know what else to do. I can only do what I can do. That's it. Trust me, I want him here. I've told him, I've basically begged to him to come back and stay here, but
have chocolate for you every day.
EBO is,
When I left my house this morning, I went back in and got you some chocolate. I was almost in my car. I was like, oh no. So chocolate, if that helps at all.
that should help. All right, I'm coming over there. Make sure I got some nice fresh coffee, and I'll answer some more questions. Talk to you soon.
Thank you for joining us for the post-op Q&A. We have Dr. Duke in the room with us ready to answer some questions, so please type them up in the chat. One of our first questions comes from a viewer on Facebook who asks, is there a limit to how many discs you can repair in one operation with DLDR?
All right, one of our viewers is asking about how many discs we can repair. The answer is yes. We've set the limit at four discs or 4 points of repair. And let me clarify what that means is that when you're talking about repairing a herniated disc in the lower back, patients come in with one of really 3 symptom complexes, okay? So you can categorize all the patients we operate on into 3 categories. The first is patients with back pain from the herniated disc. The second is patients with leg pain or leg symptoms like numbness, tingling, weakness. So leg pain, numbness, tingling, weakness. We call those radiculopathy. And the third category is patients with back pain and radicular symptoms or radiculopathy from the herniated disc. So there are 3 categories, and it's important to distinguish because the fact of the matter is that the leg symptoms, if present, determine the side of the patient that we operate on. So if a patient has left leg sciatica, pain shooting down the left leg, or numbness, tingling, weakness on the left side, we're going to go on the left side because I need to repair the herniation on the left side. That's the side that's bothering the nerve root going down the left leg. Now, if a patient has right leg symptoms, I'd go on the right side because that's the nerve root on the right side right against the herniation that I need to decompress and basically treat because of inflammation from the herniation on that right side. Now, we do have patients that have leg symptoms on both sides. And when patients have leg symptoms that are significant on both sides, likely we have to go on both sides to fix those symptoms. So when I talk about 4 points for herniations, it's not 4 discs, it's 4 herniations. So every disc has the potential of having 2 symptomatic herniations. And for patients that have a disc, say L4-5, with a herniation on the left and a herniation on the right, and both are symptomatic with leg symptoms, then I have to go on both sides at L4-5 in order to fix both leg symptoms. Now, some people will come in and say, well, my left leg really bothers me a lot, my right leg isn't so bad, then I go on the left side, unless they want me to do both sides, in which case I do both sides. So when we talk about 4 herniations per surgery that I can fix, we're talking about potentially L4-5 and L5S1 on both sides. That would be 4. So 2 discs with 2 herniations each is 2 times 2 is 4. Now for the neck, I can fix both herniations left and right. I can fix both side herniations left and right with fixing 1 disc. So in the neck, it doesn't count the same way. For me to fix a cervical or a neck herniation, I just need to go pick a side of the neck to go in on, but then once I'm inside the disc with the laser, I can fix both sides. So in the neck, I can do 4 discs, up to 4 discs in a surgery. Of course, there are some things that could happen that would make it so I stop before I get all 4 discs, but I could go in and 99% of the time I'll be able to get all 4 discs. And somebody asked me earlier in this broadcast if there was something in the neck that would prevent me from being able to do the surgery. There is. I mentioned the thickness of the neck in terms of a football player's neck, for example, or a rugby player's neck, or a wrestler's neck. So I don't want to offend anybody, but thick necks, whatever your profession or occupation may be, but we generally think of a football player's neck as being very thick. And I'm not talking about European football, I'm talking about American football. So a very, very thick neck would be difficult for me to do the cervical laser surgery. But also there's a condition where some patients will have a spur, a bone spur, in the front of the spine that actually creeps down and covers the front of the disc. And if you have a big enough bone spur in the front of your spine, I won't be able to get the surgery done, the Duke laser disc repair done. I'd have to do an open decompression and fusion. The other thing that would prevent me from being able to do a Duke laser disc repair from the front of the neck is if somebody's had a prior fusion with a metal plate that actually the plate was put in incorrectly and it's too long, so it actually goes up and covers access in the front of the disc space to the next level that needs to be fixed. So if I'm trying to fix a disc herniation adjacent to a fusion in the neck and the plate that was put in by the surgeon before was too long, it can actually cover up the disc so I can't get to it through the front because the needle will just bounce against the metal plate. But these are rare circumstances, and they can be determined usually ahead of time before you even go to surgery. So what I can tell you is that people with cervical disc herniations, I can get it done 99% of the time. 1% of the time, I'd have to not be able to do the surgery because of some anatomical consideration. We have another question? All right. Here's Sean to pose our next question from the audience.
Our next question comes from a viewer on Periscope who asks, is the Duke laser disc repair meant to replace fusions, or are there still situations in which fusion is a better option?
Well, isn't that a loaded one, huh? Yeah, thank you for asking. I think that's a perfect question, and thanks for asking from Periscope. So the question was, looking at your surgery, I think I understand, you're basically treating the symptomatic part of a disc herniation. And is this Duke laser disc repair procedure meant to replace fusions? The simple answer is absolutely yes. That's the whole point. We're here to replace fusions. And I want to also say artificial disc surgery as well. So the indication, surgical indication for spine surgery on a disc to do fusion is the same indication that we would do Duke laser disc repair. Basically, it's a problem with the disc that starts with the herniation, and that herniation can advance to become degenerative disc disease, stenosis, radiculopathy, myelopathy. All these things can happen as a result of the herniation. So a surgeon's primary goal fixing a patient with a cervical fusion or a lumbar fusion or a artificial disc in the neck or an artificial disc in the back, the primary goal is to treat the herniated disc. That's the primary goal in every single spine surgery that involves fusion. Now, there are some exceptions, and I'll mention those in a second. But 95% of spinal fusions are done for the same exact reason, the herniated disc, that Duke laser disc repair is done for. As a matter of fact, I'll point out to you that originally painful joints, such as hips and knees, were treated many, many years ago, 100 years ago plus, they were treated with fusion of those joints. So if you had a painful hip and you couldn't walk because it hurt so bad, the surgeons would fuse your hip. Of course, it would make your other hip go bad and your other knee go bad, but when you fuse the hip that's painful, you get rid of the pain. So the patients gain function overall. So fusions were the original solution to painful joints. Then artificial joints came about, artificial hips, artificial knees, artificial shoulders, ankles, whatever you want to call it. There's artificial joints for just about everything. And artificial joints are made out of metal and plastic. So you cut the old joint out using a saw. You cut the bone literally on above and below the joint. You cut right through those bones and you take the old arthritic joint out. And I hate to say this euphemism, but throw it in the garbage can. Now you have a metal joint or metal and plastic joint, a hybrid joint that you put in its place, and you connect it to those bone shafts that are residual, and now you have a joint that moves, but it's not painful because metal joints don't have nerve fibers. Now they do become painful in some cases because of where the artificial joint connects to the real bone. And that interface can become painful if there's a problem, there's loosening. But for the most part, painful joints were treated originally with fusion of the joint, then artificial joints, and now arthroscopic surgery is the most advanced, latest way to treat a painful joint. If you have a painful knee and it's swollen and you have a tear in your meniscus, the surgeon is probably going to recommend endoscopic surgery. And that's where they go in and find the tear and repair it. What I do with the spine, with the Duke laser disc repair, is endoscopic surgery. It's no different than endoscopic shoulder, endoscopic knee surgery from the standpoint of making a small incision and using a tube to go in and see the problem and try to fix it. The difference is that endoscopic knee and shoulder surgery is not as successful as endoscopic disc surgery. And what I'm doing is endoscopic disc surgery for herniated discs. So yes, I'm bypassing the treatment with fusion and artificial discs. I've been trained to do both, fusions and artificial discs. I've done over 1,000 spinal fusions in the lower back in my career and over 1,000 ACDF, anterior cervical discectomy infusions. And I've done probably about 500 posterior cervical laminectomy infusions. So my background and my vast majority of my experience is in spinal fusions. And I'm a very, very good spinal fusion surgery, one of the best in the world in terms of outcomes. I have the best results and the lowest complication rate. Nobody has a lower complication rate with spinal fusion. I've also published my results. You can look it up in PubMed, National Library of Medicine. You can see Duke Majan, and you can see lots of publications for spine. Okay? But the best surgery by far is the endoscopic surgery, because endoscopic surgery is so minimally invasive that you don't have to take painkillers after surgery with my surgery. You don't have to stay in bed. You're literally back to work the next day, back to shopping and being almost normal, because you just have some lifting restrictions and bending restrictions. You have to wear a back brace, which is Velcro and plastic, but you have to wear a back brace to kind of keep your back straight or your neck straight after surgery for 6 weeks. Aside from that, you can start driving the next day and you can go back to a normal life without taking painkillers. The only painkiller you're going to take after a Duke laser disc repair is Tylenol. Now, some people take painkillers for other reasons, but not for the surgery. For example, a patient who develops, let's say, trochanteric bursitis, which is inflammation of the bursa in their hip after surgery, and they're walking around and they're doing more walking, well, now their hip is inflamed, they may have to take a painkiller for that. But they're not going to take a painkiller for where I did the surgery. So that's a huge, 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 I can't even emphasize how huge that is in medicine. I mean, there's a big movement right now in the world to get off of narcotic painkillers, opioid painkillers. And if you have an open back or neck surgery like a fusion, you're guaranteed to be on painkillers, narcotic painkillers, for weeks, if not months. So the Duke laser disc repair doesn't require any narcotic painkillers. It's the only spine surgery that doesn't. All other spine surgeries do. So that in and of itself is enough to not get any other spine surgery done. That's putting aside the results. I mean, the results are 95% relief of pain on average. There's no other spine surgery in the world, no fusion, no artificial disc surgery that gives you that result. Go read the publications in PubMed. You'll never find 95% relief of pain anywhere, because these other surgeries can't do that. And the reason they can't do it is they're not addressing the source of pain like my surgery does. The Duke laser disc repair addresses the annular tear. The annular tear is the source of pain. When I talk to my colleagues about it, they don't get it. They don't understand it. They don't believe it. They can't do the surgery to prove it to themselves. You really have to actually do the surgery, repair the annular tear, and see the patient's pain go away to become a believer. And honestly, I wouldn't have believed it myself had someone told it to me, because I'm a very well-trained neurosurgeon, and there's no way I would believe somebody who told me that, because I'd never heard of that before. It's just hard to believe something you've never heard of before. And that's the way it was when I first started doing these surgeries almost 15 years ago, was I didn't believe that they could work. But I went and watched a surgeon do it, and I did my first case, and I've told the story before. And honestly, I was shocked when the patient came back the next day and their pain was gone. And that was the first one I ever did. And I was like, what? Really? Come on. Couldn't be gone. And it was gone. And I thought it was a fluke until I did it again and again and again and again. And I realized, oh my God, this thing really works. And more people need to know about it. So that's why we broadcast, because we want everyone to know, don't get a spinal fusion. Don't get artificial disc done. Come talk to us about the endoscopic surgery that doesn't involve any metal or implants in your body. It's outpatient. It takes an hour and a half to do, and you go home an hour later. You're not getting anything more than a 7-millimeter incision. So this is really remarkable. And no blood loss and no narcotics. No hospitalization, no being in bed. Basically being up on your feet the same day and the next day. So it needs to be talked about. More people need to be aware of it. The reason why it's not more popular, simply not because of demand or patient interest, because the companies that manufacture the fusion implants, the companies that manufacture the artificial discs, these companies are big, powerful, rich companies. They have investors, and they want a return on their investment, and they never saw endoscopic spine surgery coming, okay, despite me trying to tell them for years. They never saw an end to implanting metal and plastic into people's bodies to stabilize their spine. They never saw an end to that. That's their gravy train. That's where they've invested their money, their time, and they don't want to see it go away. You understand what I'm saying? It's kind of like the people that built the railroads, right? They invested all that money into building the railroads and the trains, and when cars came, they opposed the development of highways because they didn't want people driving their cars around. They wanted people taking the train, okay? So, you know, the people that, the companies that sell implants for the spine, these metal screws and rods, which I put in too, by the way, they're wonderful if you're doing open surgery and you have to do it that way, but they don't want my technology out there. They have already basically banned me from being able to talk about this surgery and being able to show other surgeons this surgery because they control the educational system of surgeons in the United States. They basically have, over the years, they have infiltrated the training institutions, and you can't go to a single training center in the United States without finding representatives from these companies that are paid to get the surgeons to put in their screws and rods. That is exactly what the situation has been for the last 20 or 30 years, maybe longer. And these companies don't want you people finding out about surgery that fixes back and neck problems without fusion. They want fusions to happen because they make a lot of money, literally billions of dollars a year in profits from selling these screws and rods at jacked up prices. So I'm literally a one person, the mouse that roared, okay? How do I know about this? Because I actually was in a play called The Mouse That Roared when I was a junior in high school. It was like back in 1985, 86. And I learned about mice, and I learned that mice have a voice, and that if the right people are listening, that voice will be heard, and it can change the world, okay? It's a very funny play. You should check it out sometime if you've never heard of it. But little people, little voices that need to be heard can be heard, but they won't be heard if the mouse doesn't talk, all right? So I'm talking on behalf of all of you, but I need help. I can't do it alone. I am one person. I'm the mouse. And so I need more mice, and lots of mice can make a difference, okay, in the world and can change the world for the better. That's what I believe I'm doing. And like I said, it can't happen without everyone else's support. So there's my answer to your question about fusion. Yes, the Duke laser disc repair can replace out of 1 million fusions a year. In the United States, it can replace 995,000 of those fusions. Basically, 99% of them could be replaced. by the Duke laser disc repair. Well, that was our last question. I've enjoyed talking to you. We're getting ready for our next patient. Our next patient is having a single level Duke laser disc repair, lumbar L4-5 left approach. This patient has back pain on the left side and has failed conservative treatment. They have a herniation. It's small, but it's causing a lot of pain. And they want this surgery done so they can get out of pain. So that's what our next surgery will be. We'll see